afternoon. This is Chase Napier with the Healthcare Authority. Thanks for joining. We're going to get started in just a moment here. We're going to give folks another minute or so to join, and then we'll get kicked off. All right, thanks for waiting and thanks for calling in. Again, this is Chase Napier with the Healthcare Authority. I'm the Community Transformation Manager leading the ACH initiative in Washington. So this is the first monthly Community Transformation Touch Base call slash webinar. We really are looking forward to the opportunity, and I think keeping these going on a monthly basis is our hope. But the first thing we want to point out is this really needs to be of value to all of our partners in Washington State. What we see as an opportunity here is really to open up dialogue around what the ACH initiative is, what the Accountable Communities of Health in the 9 regions are doing, and some of the linkages to Healthier Washington. I'm going to cover the agenda and then go over the purpose of the call in more detail. So if we look at the agenda for today, we're going to cover some of the logistics specifically around the Q&A section later on, just so you can be prepared and be thinking about your questions and submitting those. Like I said, go over some of the structure for this call in more detail, and part of the reason behind that is for you to give us feedback on what you would like to see going forward. Hand it over to Nathan Johnson in a few minutes to give us a really high-level Healthier Washington overview, which sets up the frame for the ACH discussion and some of the content we're going to go over in more detail. And then at the end, like I said, hopefully have some time for questions and answers. We didn't receive questions ahead of time, but you do have time during the webinar to submit those questions. So let's cover the logistics for today. We want you to use the comment box to submit your questions. Everyone is on mute. And we might be able to unmute one by one later on, but it might be just as easy for you to submit those questions ahead of time, and we'll be able to identify those, respond. The purpose of the FAQ that we sent out, and hopefully all of you have seen, we'll keep referring to that today and ongoing, is to identify gaps in knowledge and to be able to address those gaps. So we may very well take the questions that you submit, go back to other partners as appropriate, and then circle back through that FAQ and through future calls to address questions. So not necessarily every question will be addressed today, either because of the time constraints or because of the other partners that are involved in making those connections to develop the solid responses that we want to provide. And so let's then jump into, do you have anything else, Lena, from a logistics perspective?
Nope, nothing here.
So I want to introduce the team of the community transformation effort. So it's Lena Nashand and Kayla Down, who are both involved here and on the line. In addition, we have Nathan Johnson, who, as I mentioned, will take a few minutes in a moment. So Nathan Johnson is the Director of HCA's Policy Planning and Performance Division. He's also the Healthier Washington Coordinator under the Healthier Washington governance structure. So we're really happy to have him here to cover some of the Healthier Washington elements at a high level. So let's go over the structure for these monthly calls. So you've heard a few of these points already. We want to create a learning space for anyone who wants to know more about ACHs. So this is appropriate for those who are actively involved and those who are not, and maybe even more so for the latter, for those who haven't found the right mechanism to stay informed and to be able to ask questions and get responses. So that's the kind of the second piece there. What are some of those common questions, and what are the emerging questions? As partners learn more, we expect to continue to be able to be responsive to those questions. And then a framework through the FAQ that I hope all of you have seen. It's on our website. We sent it out in a distribution a few weeks ago. And this is to really establish a more common understanding of the ACH initiative, common language and messaging that we can all use. And we really think that's going to be a framework to provide much needed clarity around the accountable community of health effort moving forward. So if you haven't looked at the FAQ, we encourage you to go to the website, and later on we'll have a link directly to that so that you can make sure to visit that after the webinar today. So with that, that's kind of the structure. This, like I said, we want this to be of value, so we anticipate it being a monthly call. The caveat is next month we'll be postponing. We'll cover that later. But the idea is for you to provide feedback on what you think we could do better. We really want to keep this connected to the development of the FAQ. So as we have conversations and as we address questions, add it to the FAQ so that we have kind of the standing documentation, the common messaging that we can all refer to. And then if we need to have either more time or less time for Q&A, if you need more clarity around different aspects of Healthier Washington, we could always bring partners in to provide those updates. We could provide updates from different ACH regions. So a somewhat flexible and fluid format, but we just want to be transparent and have that kind of consistent mechanism in place. So that's the idea here. I think we've covered enough of kind of why we're on the call today, so I'm going to hand it over to Nathan Johnson to spend a few minutes on Healthier Washington before we dive into ACH overview and some of the FAQ content.
Great, and thank you, Chase. Thank you for those who've hopped on the webinar today, and I really do look forward to these monthly calls. And a great opportunity for us to exchange ideas and make sure we are really answering to the questions that may still exist around this and other Healthier Washington initiatives. What I was asked to do, and I'll be very brief in doing so, is to outline the Healthier Washington initiative, in which accountable communities of health really exist as some basic and fundamental infrastructure in driving health transformation, so that you understand what the ultimate goals are for this work, and very much so how ACHs fit into that. The ultimate goal of Healthier Washington really fits along the triple aim objective that many of you have heard before. Our triple aim is a slight variation. We want healthier people and communities. We want higher quality healthcare delivery, and we ultimately want a lower cost trajectory, not just for state-purchased healthcare like the Medicaid program and public employee benefits, but for all healthcare, making it more affordable for individuals and families, and for the taxpayer as well. If that triple aim were easy to achieve, we wouldn't be sitting here today because it'd already be done. The fact is, this is a very elusive aim and very difficult to get to. It speaks in particular to why it's so important to have community engagement and activation on these goals. Healthier Washington is bigger than just a grant, although a key driver of this is the state's receipt of a State Innovation Models grant a year ago, in the amount of $65 million over 4 years. And within that grant, there are some key investment areas, and that's what I'm going to focus on today, again recognizing that the grant alone is not the whole of what Healthier Washington represents and exists to do. First, I want to start with the issue of payment redesign, where we are making significant investments and progress, really with the idea here that as it stands now, the state, and in particular Healthcare Authority, is responsible for buying healthcare for 2.1 million people. We spend $10 billion a year in doing so for the Medicaid and public employee benefits programs. And we feel like that is a significant role with significant responsibility and accountability. And the way we've talked about that in the frame of Healthier Washington is the state being the first mover. It's one thing for us to declare the import of moving our payment system from one that reimburses volume to one that reimburses for value. And instead, we're actually trying to lead and model that approach for other payers and purchasers. We have 4 payment models, and I might just pull out and focus on 2 that are most activated at this stage. One of those payment models deals with how we purchase physical and behavioral health services in Medicaid. It's payment model 1. Some folks on this call may know that as the early adopter program. In this case, we are integrating 2 silos that have existed for a long time in the Medicaid program, especially in terms of the financing of them. That is the way we purchase physical services and behavioral health services, and integrating them into fully integrated managed care products that will first be made available in Southwest Washington in the communities of Clark and Skamania County. This launches April 1st, 2016, and is the first in a statewide transition that is legislatively mandated to occur by 2020. We're very excited about what that payment model will do for the delivery of better and more integrated services that don't artificially disconnect the head from the body. The other payment model I'll zoom in on, because it is fresh in our minds here, is what the Public Employee Benefits Program is doing and has done now by contracting directly with 2 delivery systems in the state, and now delivering an accountable care product that is being made available to public employees and has in an open enrollment process that just closed. Here, the state has elected to contract with UW Medicine and a network called the Puget Sound High Value Network, and has demanded significant financial and quality guarantees, and has extended some of the savings that will occur in the mix of those benefit offerings back to the public employee in the form of lower premiums and lower cost sharing and an all-around better quality product. Over 10,000 beneficiaries now in the PEB program have signed up for that new product offering, and we're being very excited to be joining Boeing, really as one of the largest state purchasers of healthcare in advancing this type of model. That's payment redesign in a nutshell, and there's a few other things associated. Another key investment that we're making under Healthier Washington today is in our analytics, interoperability, and measurement capacity. It requires data, and it requires actionable data to make major purchasing decisions, and oftentimes, whether you're talking about the state or the community, we have a major gap in this area. So 40% of the State Innovation Model Grant is dedicated to improving our data analytics capacity, improving the flow and interoperability of health data, again, both at a state and community level, and ensuring that we are clear and have common understanding of how we measure health performance. This is no light effort, and we've spent the better part of the first year of this effort doing an assessment of our needs in this area, and are moving very quickly into an acquisition stage come January. A third and key investment area for us under Healthier Washington is practice transformation support. It's one thing to change how we pay for services, it's a whole nother for the delivery system and providers to react to that. So as we talk about integrating physical and behavioral health care, as we talk about new value-based purchasing strategies, assisting the delivery system in making that adjustment and that leap is something we're very serious about and are attempting to do through the creation of a practice transformation support hub that is being led by our partners at the Department of Health. And I'll speak to this in a bit further in a bit, but we see the work of practice transformation, the work of payment redesign, and data and analytic capacity very much connected to the activities within the accountable community of health. Another thing under practice transformation that we're trying to do is empower consumers to make decisions at the point of care based on evidence. This is something we refer to as shared decision making, which is resourcing, again, both the patient and the provider to make informed decisions around their care options when those options are presented. And finally, the last key area I'll hit on is the area of focus today. And I think it'll be quite obvious as we describe this to you in fuller detail how interlinked this is with the other investment areas. This foundational element of Healthier Washington is called the Accountable Community of Health. These are voluntary collaboratives, 9 of them organized throughout the state, many of them that come from a historical basis and other pre-existing voluntary and regional collaboratives, all pursuing the same goal of health transformation that includes, again, healthier people and communities, higher quality healthcare delivery, and lower costs. For us, the ACH really represents the idea that it requires clinical, community, business, and government entities working together, coordinating their efforts and actions to achieve the very ambitious goals set for Healthier Washington, especially those goals that relate to whole person health. What we have had in the healthcare sector for some time is silos of activity all performing and acting with the best of intent, but very few times have we had some of the key sectors that inform health around the same table trying to move health transformation forward. If nothing else, the commitment that this agency and other state agencies, as well as public and private sector partners have in Healthier Washington, is to ensure that the 80% of factors that determine health outside of the clinical delivery system's four walls are being brought closer to the 20% of factors that are very much dictated by what happens in the clinical care delivery system. ACHs are a key structure for making that happen, and a structure we're very invested in, and a structure that we are aligning our future purchasing activities to make sure we achieve those outcomes that are in front of us. So that's a lot to cover in a very short period of time. I hope folks have been following, and if not, have asked questions accordingly. But Healthier Washington would not be achievable without active community participation across sectors. And again, I'm very encouraged to see the activities already in play at our local accountable communities of health, with much more to come ahead of us. I think I'm going to turn it back to Chase, who's going to walk you through in a little bit more detail the origins and functions of accountable communities of health as they exist today and will exist in the future. Take it away.
Great, thank you, Nathan. And yeah, that's where we're going to go next, is to the origins of the accountable community of health concept. You know, Nathan did a great job of introducing the connectivity to Healthier Washington and the different initiatives we have going on. And so then it leads us to kind of go back to the starting point of, well, where did they form and why did they form? So the important thing to note is that accountable communities of health, by design, do build upon existing efforts around the state. So while the representation and the triple aim focus, I think, is breaking ground and moving into new territory that's a much needed partnership in communities across the state, also recognizing the existing partnerships that we were able to build upon and to formalize. And so the accountable communities of health, through state legislation, through the State Healthcare Innovation Plan, started to become a formal concept. And then through the SIM grant, we were able to take what was started in the state legislation through House Bill 2572 and transition that into a more robust accountable community of health design and implementation. So you might recall, if you've heard about communities of health in 2014, we did have regions across the state that were in a planning phase. And then in 2015, we started to transition that into piloting the ACH concept in a couple of regions. And now we're moving towards statewide formal designation, which we can talk about later, and it's also addressed in the FAQ document, but really recognizing structures that are really achieving the multi-sector representation, that are achieving the structure that needs to exist for meaningful collaboration and for the concept of collective impact to move forward in the communities across the state. So a lot of progress in the last 2 years on the ACH initiative, a lot of partnerships and a lot of infrastructure and work that we were able to build upon and formalize as we're moving forward and making connections under Healthier Washington with the value that we see at the local level through the ACHs. So looking at the ongoing work through SIM, so the SIM grant is from 2015, goes through January of 2019. So we still have 3 more years, just over 3 years left for the ACH development, along with the other Healthier Washington investments. So on the horizon there is sustainability planning, and so everything that we do through the Accountable Community of Health Initiative is through the lens of sustainability and even phasing that path to sustainability leading up to 2019. So our focus in 2015, and these points will remain, are these 4 bullets you see: operational governance structure, the strong backbone support and accountability that needs to exist under a successful collective impact model. And then, as I mentioned, collective impact, really establishing that common agenda that brings together multiple sectors around mutually reinforcing activities and shared measurement strategies. So establishing those common priorities that might lend themselves to different activities and different areas of focus from the different partners, but the common vision across those sectors and across the communities, recognizing most of our needs are very much linked and very much connected to the health needs of the populations that each organization or partner is involved with. And then pathway to sustainability, which I already mentioned. So it's not too early for us to be thinking about the value proposition at the ACH level and the recognition that ultimately SIM funding does end in 2019, and that if we have proven the value of the accountable community of health, and if we have made the progress that we are projecting under Healthier Washington, then we need to be thinking about the mechanisms for sustainability. And a lot of that is through the community buy-in and the partnership that already exists at the community level. So that's an initial priority for the ACHs, even though it's ultimately a plan for 2019 and beyond. So we're going to take a look at the map for our existing accountable community of health regions. Again, we're aware that some of you are familiar with this map and maybe even some of the accountable community of health concept, but we really want to use this as an opportunity to ground everyone in the common understanding of what this is all about. And then, of course, Q&A and future calls, we can continue to move into more detail. So you can see 9 different regions here. These regions are aligned with Medicaid purchasing, so the boundaries that the Healthcare Authority, as Nathan mentioned, around purchasing Medicaid, we really see an opportunity to align our accountable communities of health with those boundaries in the partnership. It's about all individuals within these regions, so when we talk about alignment with Medicaid, that's just a starting point and that's just one piece. Accountable communities of health represent, as Nathan said, the 80% of factors outside of the healthcare delivery system. Also, they represent the 20% within the healthcare delivery system. And likewise, not limited to Medicaid. When we talk about delivery system, we're not talking just about the Medicaid population. And when we talk about factors outside of that delivery system, we're talking about everybody within the region. So that's just an important component to recognize. And the idea, as was mentioned earlier, is that we need to understand what the local health needs are, and we need to understand the local context to develop strategies to address those needs. So this isn't about one priority statewide or one solution statewide, but to achieve the triple aim of better health for our individuals and for communities, and higher quality care and lower costs without compromising health and quality. We really do think that we have to partner locally and have an understanding across sectors and across communities of what the opportunities are. So that is part of the value of the ACH initiative in these regions that, also you can see that when you have King County as a region, or you have Greater Columbia that spans 10 counties, that there is still an opportunity, and ACHs are working on the cascading engagement strategy, or at least just the opportunities to have conversations within communities. And there's alignment that can occur across those communities, but we do see the benefit of both local conversations and regional conversations to identify where there are those shared opportunities and shared priorities. And when we talk, I think it's important also, just as a grounding element, when we talk about accountable communities of health and Medicaid and alignment, accountable communities of health are not the same as managed care organizations. They're not an extension of the Healthcare Authority to receive Medicaid funding or healthcare dollars and to spend that funding, or to serve as a funds flow entity. So if you've heard of, in Oregon, they have a coordinated care organization, and that is not the same model in Washington. We do not have risk-bearing entities. These accountable communities of health are partners with the state, but they do not have any direct authority. And so you can see that addressed in the frequently asked questions document, but just to make sure when we say Medicaid alignment, we don't get that confused with a direct role of the accountable community of health to handle any kind of healthcare funding. And if you've heard of the Medicaid transformation waiver, then there's another conversation we can have, and that's part of the FAQ. So we're not going to get into much detail there, but other than to clarify the role of the ACH as a partner, but not any direct authority that otherwise belongs to the state or managed care organizations. So I think you have the picture of accountable communities of health that's represented in these two bullets here. We've talked a lot about this. This is just an example of the sectors and organizations that are around the accountable community of health tables. It does vary somewhat in different communities based on the size and population, but you're going to see a diverse representation in every region around the state, and this is a good example of what that might look like. And we talked about the local strategies based on local priorities, and that's one of the key roles of the accountable community of health. And they've actually been working on regional needs assessments and inventories, and so we really want to start in 2015 and early 2016 with a good understanding across communities of what are the existing initiatives and resources, and what are the existing assessments. So we have county assessments, we have assessments conducted by hospitals and other organizations. So developing rather than coming at this from a blank slate, leveraging the great work that's already been done and then bringing that together to have conversations that we haven't had the opportunity to have in the past across sectors and communities at a regional level. So that's reflected there in the idea under the second bullet. So you heard Nathan talk about these three elements. The top one represents the ACH, and we're using Southwest Washington just as an example to go over quickly here. So he talked about the ACH, he talked about integration, and so integration of behavioral and physical health, and then also practice transformation. So in Southwest Washington, we can start to connect the dots and to see why the ACH provides an incredible opportunity to weave together the different investments under Healthier Washington. So at a local level, Southwest Washington as a region is really aligning these three. So as they work on integrated care, behavioral and physical health, they're also leveraging the practice transformation supports that the state is moving forward under Healthier Washington and the SIM grant. And you can see there clinical community linkages. So the ACH is an incredible opportunity to take what otherwise would be a delivery system that's maybe disconnected from the social supports and the community supports that exist, and to really link those two. And so in the early goings, we will acknowledge that, but Southwest Washington is a great example of how they're taking practice transformation to further the integration effort, and that's possible through the Accountable Community of Health, through the Southwest Washington Regional Health Alliance and the partnership that exists there and the role that they're able to play, because they do have the 80% outside of the delivery system and the 20%. It's just the perfect opportunity, and we see this happening in regions across the state. The move towards integration that Nathan covered is happening at different paces and through different phases, and Southwest Washington is on the front end of that. So we wanted to use an example of how they are maybe a step ahead on the integration effort, and using the ACH as the key vehicle to make that a reality. So with that, that's the overview we wanted to cover on an ACH kind of 101 level to set the frame. We can potentially provide other examples. I think we'll see what questions we have after I cover the kind of the structure here for the Q&A. And then if we don't have any questions, I think we can provide another example or two. But so just to kind of lead into the question and answer section here, please do use the chat function to submit questions, and then we can respond to those as they come in. The format going forward is we really do want to receive your questions ahead of time, because sometimes this will require connecting with the different investments and the leads for those investments. So for example, if there is a question about the global Medicaid transformation waiver, if there's a question about practice transformation and the different linkages, we want to be able to work with our partners here at Healthier Washington to prepare and bring those responses to you, and also incorporate those in the FAQ. So going forward, as much as you can submit questions to us through our email, which you'll see here in a minute, we appreciate that. But for today, we haven't received any formal questions ahead of the call after the release of the FAQ document. So we'll just address what we can based on your comments. Okay, so one question regarding engagement with ACHs, and I will point back to the FAQ because some of this is covered there, but just to elaborate on that, what are the opportunities to be involved in the regional accountable communities of health? So we need to recognize that there are different structures and different membership or participation opportunities, really, rather than even labeling it as membership. At the board level or the leadership council level, there are broader opportunities through a coalition. So sometimes you'll have a decision-making body that is more nimble and with limited representation of the different sectors. And then there would be an opportunity for community partners and others to be engaged in a larger setting. And that exists in most regions, if not all. Also county forums that are connected to the ACH effort. So there are different mechanisms that we can try to get you plugged into. Also, we have contact information for the ACHs on our website. But the point really is that the ACH as a structure is a representation of all the work that really occurs beyond the structure. And so getting involved in the different projects and the different Healthier Washington initiatives that are underway doesn't necessarily mean that you're going to be at the ACH board or council. We would love to get you connected to the extent we can, but there are so many opportunities even outside of the specific participation and representation. And then the other thing we would say is connecting to your organizations and sector representatives. That's the whole idea, is that we're going to have a limited number of workforce development representatives or supportive housing representatives, but being able to have that conversation with partners within and across organizations, and then bring that voice to the ACH. That's the intent too. So we're going to continue to make those connections for you. Please do remember, just keep submitting any questions you have. We'll take a few minutes and then wrap up if we don't have any others. Okay, so another question we got is let's see here, what kind of relationship do we envision between the ACH and county level activities such as rural county coalitions? And I think that's an incredible question, because the whole idea here is not that the ACH would replace existing coalitions, but really at a regional level, how can the ACH take those discussions and connect those to other efforts in other communities and to inform regional priorities. So we would love to see a clear linkage. Maybe there's an opportunity to share the different priorities that are being discussed and the different strategies that are being discussed, define some of those commonalities, find some of those areas of overlap, and also recognize where there might be specific ways for the accountable community of health to recognize that some of the issues or the solutions at a local level in a rural setting might be different, especially in some of these large regions, such as the Greater Columbia region or the Better Health Together region. And that's something we do here a lot, is that we can't lose the idea that there are really truly local solutions. By local, we don't just mean regional. We mean the conversations that are happening at a zip code level within the community, and that's connected to a regional vision, but that there are still opportunities to really pull from that voice and the coalitions and the efforts that already exist. So that's part of, I think, the inventory idea that we are moving forward to better understand what are those conversations and what are those initiatives that are underway. How do we not reinvent, but really support those efforts? So I think that's a great question, and something that we're striving to incorporate in the ACH at the regional level. And then another question, just examples of when we talk about the 80-20 proposition, what are some of the examples in the ACH that represent the 80% as opposed to the 20%? So we, of course, can identify different providers and health plans and public health individuals and behavioral health providers in the 20%. But in the 80%, we see our school system partners, our workforce development partners. I mentioned earlier supportive housing, criminal justice, and the list can go on. We're really looking at the community leaders and organizations within the community-based organizations and nonprofit organizations that are really addressing the health of the population, but maybe not in the traditional healthcare setting. So one of the important factors as ACHs mature is to make sure we maintain balanced representation. I think a lot of times these coalitions either started as healthcare delivery system coalitions, or maybe on the other end of the spectrum, really about social supports and kind of the non-traditional health characteristics, and we're trying to merge those two. So that's the concept behind the 80-20, and we really have set a standard that we won't have a dominant sector, and right now I think that means we won't have a dominant healthcare sector. That seems to be the larger challenge between the 80% or the 20%, and so we're really maintaining that consistent standard of not having a healthcare sector that is dominating the conversation. So one of the questions we also received here is examples of issues that the ACHs have identified and addressed. And an example of that issue was a specialist network. And so I guess we would have to go back to kind of the status of where ACHs are, and there are different degrees of development because of the fact we built from what was in existence already in some regions. In other regions, it was really a new concept. And so the standard that we can see statewide is that they're all working on these inventories that we've talked about. They're all working on regional health improvement plans. So they're trying to identify what are our priorities, what are the needs based on the assessments that have been conducted in different counties and different communities, and bringing that together for that common understanding of the landscape within the region and the needs within the region. So we would think the next step then is, well, what are the solutions to address those issues? So I guess what we're saying is that not all ACHs have achieved that level of recognition and then solution. We're moving into that phase in 2016 to start to take the priorities and crosswalk that to specific strategies and specific projects. And we're going to see at least one project identified in 2016. I think a lot of our ACHs are identifying more than one project. So we're going to have more detail. Well, we will provide one example, though, just it's not addressing that specific question around the network, but taking Cascade Pacific Action Alliance as an example, because they were one of the two pilot regions that we mentioned. So they identified a priority around adverse childhood experiences. And so they used their multi-sector discussions at the ACH level based on the various partners and community members to talk about how do we address adverse childhood experiences. And so in a somewhat unconventional approach that's pretty cool, they identified the need to incorporate behavioral health risk assessments in the school. So the staffing those risk assessments, developing the tool, and then making the referrals not just to behavioral health providers, but also to primary care providers. And so really that's, I think, a good representation of a priority that they saw around adverse childhood experiences, and what are some of the ways to connect the 20% to the 80%. And they did that working with their partners around their table. I think they actually have already scaled that to more sites than they plan to. Still in the early process, so don't have a lot of evaluation underway or results, but I think it's a great example to see the opportunity that exists when you're having conversations across different sectors that might not have otherwise been possible. So another question here, kind of referring to the state's involvement. So the specific question is, to what extent are we facilitating these conversations between different providers? And so I think we do see an opportunity outside of the discussion at the ACH level, because you can see the connectivity across the different Healthier Washington investments. So the state has a role to convene health plans and delivery system partners at a state level. And so we have had meetings even recently. In November, we held kind of a key stakeholder meeting at the state level to bring together partners, not so much focused on specific ACH, but focused on the Healthier Washington initiative and thinking about the connections between our transition to value-based purchasing, the use of practice transformation, and the role of the ACH. And we did facilitate a conversation with many of our health plan partners, our managed care partners, and providers. So that's a kind of at a state level that I think we'll continue to have those discussions, and that's part of the statewide effort. We also see a clear benefit in having those conversations across providers at the local level. And so I think one thing we'll not address in detail, but take this as maybe a follow-up, is what's the connection more closely to Practice Transformation Hub. And that model is emerging, so it's not implemented yet at the regional level, but there is a role and there is a connection to the accountable community of health, and how can the Practice Transformation Hub, in partnership with the accountable community of health, facilitate those types of conversations across providers and to share some of those best practices and learnings, and especially as we talk about clinical community linkages and trying to make the connection to the community and also make the connection from the community to our integrated care model. Lots of opportunity there, and I think we will continue to see that evolving through some of the practice transformation and accountable community of health work. Okay, we will do a couple more questions here. So one question, because of we haven't talked much about the Medicaid transformation waiver, and that's by design, because this call is really about accountable communities of health. But there is something we wanted to cover regarding the Medicaid transformation questions, and that's just specifically the project submission. So if this isn't registering, that's okay. And
Can't do that.
oh, sorry, I think I caused the screen to go black. Anyway, the question around Medicaid transformation projects. We did recently release an opportunity just to get project ideas for the Medicaid transformation waiver. And like I said, if this isn't registering, that's okay. This is our first call. We're going to talk more about the waiver, but the time-sensitive nature of this is why we're going to address it specifically. You are all welcome to submit project ideas. This is not a project application. The deadline is January 15th. There's been some question about the role of the ACH in project submission. ACHs, like any organization, are able to submit project ideas, but this is not a specific role that the ACH is taking on. They're not required to submit. They're not required to coordinate submissions of different partners within the region. So we just wanted to make that very clear that this is just a project idea submission process and a collection process. We're trying to cast a wide net of what might those projects be under a Medicaid transformation waiver. and no real distinction there between whether an ACH coordinates submission or not. So just wanted to clarify that, and then if that causes you to think you have more questions and you want to know more about the Medicaid Transformation Waiver or these projects, we do encourage you to visit the website that you're going to see on the screen on the last slide. That has our link, and then from there you can navigate to all sorts of other resources, including the Medicaid Transformation site. You can also contact us. We'll put you in touch. And we can also circle back if there are specific topics we need to address on this call. We'll do so and pull those partners in. Okay, I think just one last question that we have here to address regarding how often we expect to update the FAQ. And we really want that to be in sync with these monthly calls to the extent possible. So if we identify questions either on the call or after the call, to the extent we can, we want to incorporate those into the FAQ, including responses in time for the next call. Of course, that all depends on when questions are submitted and other priorities, but our goal is to really link this call to the FAQ so that we're not just representing that message here on the call, but that it's part of the official website through the FAQ so that we can all refer to it. And this is a supplemental opportunity. It shouldn't be the only opportunity for you to get the information you need. So that's our intent, is just to keep that as fluid as possible. We'll also make it very clear when updates are made, and when there are revisions, we're going to have a kind of a tracking log on the FAQ to show those updates as they occur. So it's a great question. Okay, we don't have any other questions, so for the sake of your valuable time, we will, I think, cut this short about 9 minutes, and we look forward to the next call. So we don't have a call in January because there was a conflict on the day that we typically will have these scheduled. So don't expect a call in January, but we do have one on February 18th. So that's a Thursday, February 18th, at the same time, 2 p.m. And same, we'll be able to send a registration link out. It will also be posted on our website. So look for that. We thank you for joining us, and please do visit our website, send us questions to our email, which is listed there. Look for updates, and then we'll hopefully see you on February 18th, where we can pick up on some of the new questions and new level of detail. All right, thank you all.